Thanks so much, Bruce, and thanks to the organizers for the invitation. So I'm going to talk about CMV aging and treated HIV. Here are my disclosures. Merck donated the drug for the clinical trial I'm going to tell you about, and my other disclosures are listed. So to set the stage, we know that, and as we've heard, people with HIV are at higher risk for morbidity and mortality than the general population, despite suppressive antiretroviral therapy. And this is particularly true among people who have persistently low CD4 counts, despite antiretroviral therapy, so-called immunologic non-responders. If you don't get above 200 despite suppressive ART, your mortality risk is 25% in 10 years. So that's a particularly high risk group of interest. And it's also true that women have a greater impact of HIV on life expectancy. There's a greater life expectancy gap among women with HIV compared to the general population than there is among men. So those are two groups that are of particular interest to us. We know that inflammation persists despite antiretroviral therapy, as you've heard a little bit about in the last talk, and is associated with many of these risks, but we don't really have any effective interventions that reverse that inflammatory state. We also know that frailty is increased in people with HIV, including a lot of the work from people in this room, like Christine Erlandson, and it's been linked to inflammation. And CMV has been linked to all of these things, persistent inflammation during antiretroviral therapy, so-called immunosenescence phenotypes of T cells in the general population that were linked to premature mortality or earlier mortality in elderly cohorts, going back decades now. Similar observations have been seen in people with HIV as well, a link between CMV and frailty. But no one has ever really formally tested in a clinical trial this concept. These are all observational links. And so that's what we wanted to do. And our own group's first crack at this was to test valganciclovir, which is really a pan-herpes virus drug. It treats CMV, but also most of the other herpes viruses. And we enrolled people with suboptimal T cell recovery during antiretroviral therapy, and we showed that it reduced immune activation, T cell activation, but also soluble TNF receptors and soluble CD163. Shown here, all of which predicted increased morbidity and mortality in observational studies. So we were quite excited by this concept, but what was unclear to us at the time is whether these effects were mediated by CMV suppression, or could it be that valganciclovir was suppressing some of the other herpes viruses, and it was really those other herpes viruses that were mediating these effects. And so working with Sarah Gianella, Scott Latonder, Christine Erlandson, many others, and a large team in the ACTG, we designed this a study of letermovir, which is a CMV terminase inhibitor. This drug is unique in that it only targets a single herpes virus. Just CMV, has no antiviral activity against any other herpes viruses, so we can really tease out what's the effect of CMV. Because again, we were interested in people with suboptimal T cell recovery. In yellow, about half of the people had CD4s less than 350. We made sure of that, and we also made sure we got at least a third women in the trial, because we thought not only are these groups at higher risk, but we also thought that treating CMV might be more effective in those groups. And so the design was to treat people for 48 weeks or a control group of no CMV treatment, and then observation for 12 weeks afterward. And we had built in, so there were 4 linked research grants to this trial, lots of bells and whistles and sub-studies, and because of all that, and because it was a long-term trial, the ACTG required that we have a futility analysis after the first 40 people were enrolled to see whether we were on the right track at week 8. Were we seeing similar things to what we saw in the Valgain cyclovir trial? And so when we paused for that futility analysis, this is what we had. We had about 20 people in each arm, about nearly a third women, nearly a half with CD4 is less than 350, and most were CMV seropositive. They're all ART suppressed, and most were in their late 50s. There really weren't many safety concerns here, maybe some mild diarrhea or headache in a small fraction of people, no severe adverse events that were thought to be linked to drug. CMV was quite effective, or letermovir was quite effective at suppressing mucosal CMV shedding. We looked in the throat, semen, rectal, and cervicovaginal swabs. There were 2 people during letermovir therapy at an early time point that had detectable CMV DNA in semen, but it was far lower than where they started. And interestingly, you'll see on the right, even post-treatment for up to 12 weeks, suppression of CMV shedding persisted, which is really intriguing. That's something we saw in our earlier Valgain cyclovir trial too. And all the plasma CMV DNA tested in the study were undetectable. So all this is happening in tissues, it's not happening in the blood. So here's the results of the futility analysis. The exact opposite of what we hypothesized. And so my colleague and former mentor Steve Deeks tells me this is my specialty. Not just that my a priori hypothesis is wrong, but that it's 100% wrong. But it's actually my favorite result in science, because whenever that happens, you always learn something new. In retrospect, I think the declines in these markers that we observed earlier represented declines in other herpes viruses besides CMV. In fact, the CMV effect, at least for soluble TNF receptor 2, went in the exact opposite direction. And so what is going on here? So we were actually quite, Scott and Christine probably remember this. We had a team call after this happened. Everyone was depressed, like we had all this time and energy invested to study what happened. But I was kind of excited because I knew we were going to learn something. The first hypothesis is basically what I'll share with you here is going into this, we had this pretty simple idea that CMV is just going to amplify inflammation. TNF alpha induces lytic CMV replication in infected macrophages, and then those CMV virions are then recognized by the immune system, amplifying the inflammatory signal. And there are several mechanisms by which that may happen. But CMV is a wily virus. It does a lot of things. It's got over 213 open reading frames in its genome, and it's and if you look at the proteins that those genes make, it's like a textbook of human immunology. It has multiple immune evasion strategies, and one of the most important ones is viral IL-10, this immunoregulatory cytokine. It's kind of a brake on the immune system. It actually suppresses myeloid cell activation. And it will reduce TNF alpha production. It will decrease antigen presentation. It's actually a strategy by which it evades host immune responses. And so if you think about it, CMV is kind of doing 2 things at the same time. It's got its foot on the accelerator and the brake at the same time. And when you treat with letermovir, you're reversing both of these effects. So you may reduce some of that direct inflammatory effect, but you're also taking the foot off of the brake of the IL-10 axis. And all of a sudden, you're waking up those antigen-presenting cells. They're now presenting new antigens to the immune system, and you're getting immune activation. And we saw evidence for this in the trial. We looked at IL-10 receptor alpha levels in the blood, which is a marker of IL-10 receptor activity. That went down in the letermovir arm significantly, whereas human IL-10 levels didn't change. So something was causing decreased IL-10 receptor activity, and it was not human IL-10, We suspect it was CMV's viral IL-10 that we were suppressing, taking the foot off of the brakes. But when we looked at the broader inflammatory proteome in the plasma using two large Olink panels over 700 proteins, this is a volcano plot that basically profiles changes with treatment, in all these proteins. And if the dots are over to the left, that means they went down to a greater degree in the letermovir arm than in the control arm. And you'll see a lot of stuff is shifted over to the left, right? And I've listed on the left-hand side there the classes of proteins that were preferentially reduced by letermovir. There were a lot of inflammatory proteins, IL-6 receptor, APRIL, others, a lot of chemokine receptors, complement pathway proteins, endothelial dysfunction and atherosclerosis and angiogenesis-related factors reduce. And so a lot of these that are linked to end organ disease, and many of them linked to both cardiovascular disease and cancer risk. So all in all, while there was this at least early increase in some inflammatory markers, the more general results seem positive. And when we looked at the 5 proteins that the Insight Network recently found were causally linked to cardiovascular disease and treated HIV by Mendelian randomization studies, it's leveraging the power of host genetics to determine causality. They found these 5 predicted an increased risk of MI, and 3 of those 5 were reduced by letermovir. And so going back to the soluble TNF receptor 2, patients are actually followed in the trial until the analysis was complete, and so most of them had completed 48 weeks of treatment by the time treatment was stopped, and so we were able to follow things. It turns out that by week 48, TNF receptors actually went down. This is a transient increase that had occurred, and we saw similar patterns for CRP, IL-6, and D-dimer. But other immune activation pathways that we think are really important and causally related to disease, like IL-1 beta, went down early and they stayed down in the letermovir arm. And IL-1 beta we know is causally linked to heart disease as well as cancer mortality and lung cancer incidence in the CANTOS trial in the general population of people with heart disease. What happened with CMV-specific IgG titers, as you might expect by removing the antigen, they declined, and after we stopped CMV, despite no evidence of an increase in new CMV shedding, the antibodies started coming back, suggesting that the immune system was starting to sense CMV again. And if you look at some of those immune risk T-cell phenotypes I referred to earlier, the so-called markers of immunosenescence, I don't like that term because I don't think these T-cell changes are causally related to disease. I think they're markers that predict mortality in the elderly, but I'm not so sure that they're causal. They did decline, certainly with CD4s, and then with the CD8s, you see that transient increase along with some of those inflammatory markers followed by declines. Another common marker associated with immune risk phenotypes is the CD4 to CD8 ratio. You all know it's low in people with HIV. It's particularly in the case of CMV co-infection. And so it's long been suspected that CMV is a key driver of this low CD4 to CD8 ratio. And these are the first evidence that, in fact, it's causally related to a low ratio. Letermovir increased the CD4 to CD8 ratio quite significantly. And the effect size, we related this to its a relationship to infection-related cancer in the NA Accord studies. And this corresponds to about a 14% reduction in non-Hodgkin lymphoma and anal cancer at 1 year. But as you see, the curves are continuing to separate, and so who knows what longer term therapy might have done. And then the really cool part came, and this I owe great thanks to Christine Erlandson for this. She really advocated for us to include markers of physical function in our study. And so we did this 5 times chair rise test. A lot of you in the room probably know that this exam very well. It was new to me, and you basically stand up without using your hands as fast as you can 5 times, that improved in the letermovir arm by nearly 2 seconds. And Christine. And significantly different between arms. And Christine tells me that an exercise intervention, you can expect to see 2 to 3 second improvement. So we're getting close to an actual exercise intervention on physical function, which just blew my mind. And so we thought, okay, this is just one measure, and maybe this is just a fluke. But what really sold it for me is that there was a very strong correlation between the improvement in chair rise time and the improvement in the immunologic markers. This is the CD4 to CD8 ratio, and it was true even within the letermovir arm itself. We saw the same thing with improvements in IL-6 receptor and IL-1 beta, both strongly linked to the improvement in chair rise time, so that was really important to us. And then lastly, these are new data that haven't been presented before, but we explored interactions by those baseline groups. We thought it might work better in women, and it appeared to. So looking again at the volcano plot of biomarker changes, there are more on the left side here suggesting greater improvements in women than in men, and also greater improvements in those greater declines in people with low CD4 counts as well on the right-hand side. And so treating asymptomatic CMV with letermovir improves immunologic and functional aging, at least markers of these processes. And durable, it causes a decreased mucosal CMV shedding, and which persists for at least 12 weeks after we stop therapy. There is a transient increase in some inflammatory markers, TNF receptors, IL-6, CRP, but it's early, and there's subsequent sustained reductions in inflammatory markers that are linked to cancer risk and heart disease. We see improvements in other immune risk markers, also improvements in physical function, and these effects are seem better in women and those with low CD4. So the clinical implications are still unclear, and we're hard at work now at pushing forward with a new trial in the ACTG to attest this. But we believe that this is the most promising immune-based intervention yet for treated HIV that has the potential to affect not just cardiovascular outcomes, but all aging-related outcomes in people with treated HIV. So I'll stop by acknowledging all my colleagues, and in particular Sarah Gianella from UCSD, who is my co-chair for this study. A lot of blood, sweat, and tears went into this, and Sarah has been a great champion for this, as well as all the rest of our collaborators, many in this room, and our funders, the ACTG and Merck, for providing drug. So thank you.